Good morning. Welcome to Grand Rounds at the UCLA Department of Psychiatry. I'm Michael Gitlin, a member of our department, and I'm thrilled and honored to introduce our colleague and my good friend, Mark Frye, as our speaker today. Mark is a consultant in the Department of Psychiatry at Mayo Clinic. He is the past chair of the Department of Psychiatry at Mayo from 2010 to 2020, and has the honor of being the Stephen and Shelley Jackson Family Professor in Individualized Medicine. He was born in Rochester. He's a child of Mayo royalty. He received his MD from the University of Minnesota and did his psychiatric training at this little place with the red brick buildings here at UCLA. He then did a fellowship at NIMH working with Bob Post on the mood disorders intramural unit, focusing on the neurobiology of treatment-resistant depression and bipolar disorder. Mark then came back to UCLA, was a faculty member here for years with an office that was about 6 feet from mine. And he and I were the only ones who got here at 6:45 every morning. And so we would gossip for 15 minutes before our day was on. And that's when we became such good friends. He was also an integral part of the the bipolar research group, which was Lori Altshuler and Mark and myself. And those were a glorious time when the three of us worked together. Then he went back to Mayo, was a senior consultant, and then became chair of the department. He has been, this is not on his CV, but I know this, an extraordinary mentor at Mayo. People from all around the world, junior psychiatrists, would come and work with him, and Mark's generativity was legendary. He's just launched so many young psychiatrists' career as a field. We should be utterly grateful to him for that. He also started the Mayo Clinic Individualized Medicine Biobank for bipolar disorder, which is large and expanding. He's been a very active clinical investigator with research support from endless places and has published more than 450 peer-reviewed articles. He is among truly the foremost world authorities on bipolar disorder. He's also received endless awards. I won't go over all of them, from the American College of Psychiatry, the Jerry Clerman Senior and Young Investigator Awards, ISBD Awards, and he won multiple teaching awards when he was at UCLA, both for medical student and resident teaching awards. Well deserved. He's also president of the National Network of Depression Centers, the NNDC, which is a multi-site organization. He's the scientific chair, the Scientific Advisory Board chair of the DBSA, the Depression and Bipolar Support Group. And he's going to talk today about his most recent leadership position. He's one of the scientific co-chairs of what's called BD Squared, Breakthrough Discoveries for Thriving with Bipolar Disorder, which is hoping to have thousands of bipolar patients across multiple sites. UCLA is honored to be one of the 6 first sites, with Jennifer Cruz being our site PI, David Bicklutz and I being the co-PIs, but Mark is one of the co-scientific directors, and he's going to talk about that today, and we're so thrilled to have him back. Mark.
Thank you, Michael. It really is just a thrill to be back. The campus looks really different. And I was walking onto the 3rd floor today for a great lecture in late life depression. I thought, this is where I started my internship with Jim Spar on 3 South. It was surreal. And best we leave it at that. So I am really pleased to give you a whirlwind tour through clinical gaps in bipolar disorder and how that really drove our interest to build a learning health network with UCLA, and excited to tell you about BD Squared. So my disclosures are here. I will be presenting some pharmacogenomic data that is not part of my grant listed above. This was funded through Mayo Clinic. And I think part of the problem, Jonathan had asked in the assignment to kind of give some personal remarks, either as an investigator or as a clinician, as to why I chose this topic. One of the reasons is that bottom label. We have so very few treatments for bipolar depression. Whatever we use generally is an antipsychotic or is uniformly off label. That is the disclosure you need to know, and that's actually really part of the problem. Personal experiences. Several patients of mine have had memorable, tragic consequences of being prescribed an antidepressant by me and becoming manic, psychotic, arrested, terrible outcomes. And I think for clinicians in the audience, at least in this field, in this era, when I kind of think about the most uncomfortable learning situations for me has been in the context of a switch into mania, a life-threatening rash with lamotrigine. You never forget these patients. And I think if there's a way that we can learn from these terrible adverse events as to how not to repeat them, I think we've actually advanced in the field. That's the personal perspective as a clinician honored to work with individuals living with bipolar disorder. I would add that from a clinical perspective, I look at the field of schizophrenia and major depression and all the anxiety disorders with some disappointment that we've not had advances like that from a regulatory approved standpoint for treatments with bipolar disorder. And while I am a great believer in serendipity and understanding how lithium came to our practice and mood stabilizing anticonvulsants, I as a clinician would really like to see discovery science lead to novel drug development, and we'll talk a little bit about that today. For objectives in 30 minutes or less, want you to appreciate the burden of the depressive phase of bipolar disorder, and then have you think about how very few treatments clinicians have in targeting those symptoms in comparison to mania or major depressive disorder. The second and third blue bullet has been a real passion and priority for our group at Mayo Clinic. How do we bring greater precision to existing treatments? And I think one of the ways to think about that, perhaps not right away, is when not to do something. So we always kind of think about pharmacogenomics of treatment response. How about pharmacogenomics of an adverse event, that we steer away from that if we have knowledge to do so? Want to show you some of our work in the spirit of not discovery science, thinking about novel therapeutic development. This is in its infancy, but it's a way that we like to think, and then really bring all of that to our final objective with a learning health network getting started here at UCLA. So I'm going to really focus on the bottom three bullets as we're really thinking about the depressive phase of illness. My work being mentored by Michael Gitlin and Lori Altschuler here, that point came home very clearly when we really saw that subsyndromal depression in bipolar disorder, a point where the clinician might just rest easy, there's not a lot to do, but that actually had significant correlation to functional impairment and was a prodrome to relapse. The longer that subsyndromal symptom sat there, the more likely it was going to be a functional syndromal episode. I think what surprises many people is to really recognize that the disability or the real economic burden in this illness is not mania, it's depression. When you look at workdays lost, underproductivity, or disability, it is the depressive phase of bipolar disorder that drives most of that. That last bullet has been some work of ours at Mayo Clinic, really comparing the cost of care for bipolar disorder in comparison to major depression, type 2 diabetes, coronary artery disease, and asthma. Bipolar by far had the greatest cost, with the exception of a coronary artery disease diabetes comorbidity. And the costs were widespread. It wasn't unique to hospitalization. There was one study that showed significant pharmacy costs, but another that really showed significant burden from the standpoint of inpatient and outpatient addiction treatment. So there is a burden with this phase of illness that we need to better understand to better treat. I wanted to take two examples that have been understudied and that have been a focus of our group to think about specific burdens and how they might differ in unique populations. So while the prevalence rates of bipolar type 1 disorder is equal amongst men and women, bipolar type 2 disorder and depressive predominant disease is far more common in women than men. That can be depression in mixed presentation. So that can be depression in rapid cycling, that can be depression and anxiety. And each of these has been associated with increased rates of depression. And when you start to think about how good we are at treating the depressive phase of illness, you see a lot of treatment resistance here. What makes this more challenging for women is when we think about when we think about medical comorbidity patterns. First, starting with endocrine disorders, all of us know that thyroid illness is far more common in women than men, and not surprising, far more common in bipolar women than men. The way I think about this is common pathways of treatment resistance. If there is treatment-resistant bipolar depression, if there is a poorly controlled Hashimoto's thyroid presentation or a thyroiditis, we increase the complexity of the illness and we increase rates of treatment non-response. From a cardiovascular disease standpoint, what I find really striking is to recognize that the risk of cardiovascular disease in bipolar women is higher than bipolar men. And that is the exact opposite of the general population. What are the mechanisms or the associated factors of that are not clear, but something that, again, can drive greater treatment-resistant depression. And then finally, cardiometabolic, so the metabolic syndrome, or simply just increasing BMIs related to psychotropic weight gain, related to atypical symptoms of depression. We can see this in bipolar women. So I have had just the absolute honor to be mentoring a number of health science researchers at Mayo Clinic who've been interested in health disparities. And I thought I'd take a moment to walk you through several of our studies and really kind of emphasize the importance of racial disparities in bipolar depression or bipolar treatment, I'm sorry. So on the upper left is Margaret Atkin-Hame, who completed her health science PhD at Mayo Clinic and went on to the CDC. When we were building our bipolar biobank, we wanted to really look at rates of participation by different races and ethnicities, and not surprising, we found a significant under-enrollment of bipolar patients of African ancestry. That first paper, Racial Disparities, a Call to Action, really was an important exercise for us to recognize disparities in diagnosis, treatment, and research participation, recognizing higher rates of misdiagnosis, specifically men with schizophrenia, which quickly brought in the concept of how do we attribute psychosis, and is there a racial bias to how that might be, or a set of sociocultural factors that we're not fully appreciating when we ask those questions. Margaret's paper really galvanized us to start thinking about data sets while we built our biobank to start looking at. And that's the second paper that's at the bottom. And that was written with Margaret and Suleiman Elamin. And his day job is a psychiatrist, but he is a wonderful artist. And that is a piece of work that he's done. He has various compositions during significant phases of his professional life, and it's been really just an honor to watch him flourish, not only as an artist, but as a scientist. So the bottom paper was really looking at a public data set, the GAIN data set, where we looked at how diagnostic criteria was met for mania in bipolar patients of African ancestry versus European ancestry. And it became very clear that bipolars of African ancestry had less kind of classic core manic symptoms, grandiosity, a sleep-deprived energy enhancement. And it may be that simple fact that contributed to significantly less utilization of lithium and other classic bipolar treatments in very significant ways. Monica Taylor Desir, who's in the middle, is a Robert Wood Johnson scholar at Mayo who has done some of the first analyses of our bipolar biobank and has shown that individuals of African ancestry have higher rates of cocaine use disorder, PTSD, tardive dyskinesia. So clinical correlates or comorbid patterns that really contribute to greater morbidity and greater treatment resistance. There's a much larger story in this space of bipolar disorder as it relates to racial bias, unethical behavior, discrimination. But this, and we want to address that, but this really got started in the context of recognizing our inability to optimally care for a segment of our bipolar patient population. And I think this work will continue forward. A second example of that, I'm sorry, we've set up a really interesting collaboration with the University of Mississippi Medical Center, and we asked them to look at their data sets. So that's the UMMC. And you see a second data set that is really a first look at some of the bipolar patients who have enrolled in All of Us. This is a NIH-funded national precision medicine initiative. The biological samples are stored at Mayo Clinic. What Dr. Chirikoff is showing you is that in comparison to bipolar patients who are white, individuals who are Black had less utilization of lamotrigine, less utilization of carbamazepine, less utilization of any anticonvulsant, less utilization of antidepressants, less utilization of lithium. Antipsychotics is not the difference here, but when you start thinking about the depressive phase of illness or bipolar disorder and classic mood stabilization, there is a gap in treatment. So, recognizing the burden of depression overall, a particular emphasis in women and bipolar patients of African ancestry, I want you to appreciate the just dearth of regulatory approved treatments in this space and the need for us to do better. So the depressive phase of bipolar illness has 4 FDA approved treatments. They're all antipsychotics, and one is in combination with fluoxetine. Recognizing when bipolar individuals are symptomatic of their illness, they are far more likely to be depressed than manic. Those 4 treatments compared to 12 for acute mania was 11 until last week with iliperidone's approval. 8 treatments for bipolar maintenance and 28 treatments for major depressive disorder. We're not even counting TMS and all of these other novel digital interventions. And one of the drivers for me in this space is really recognizing that really good clinicians use these antidepressants all the time with very little evidence base overall. Thinking about standard treatments, lamotrigine, while it has a maintenance approval, it's very clear its efficacy in the acute phase. I want to recognize David's work and the critical advances we've made in evidence-based psychotherapies, really highlighting cognitive behavioral family and interpersonal therapy, really having a high priority in treating depressive symptoms. And there had been a 2020 FDA regulatory breakthrough designation for TMS. I think it'd be fair to say that it's hasn't really sort of come forward as to how helpful that is for the depressive phase, waiting for good data. So what bothers me as a clinician is the bottom part of this slide. There will be no pursuit from a regulatory standpoint of intranasal ketamine for bipolar depression. Novel treatments like dextromethorphan, bupropion, no plan. Psilocybin, no plan. I have a remarkable ability of conducting negative studies, and I've been very involved in the modafinil study was here. The armodafinil studies were broad, and the meta-analysis is positive, but the individual studies, I suspect, related to complexities of study design were not positive. So let's talk about, and this is a biased, select review of the literature, but I think there's three main teaching points if we want to think about antidepressants and bipolar disorder. That first blue bullet, there's not been a study since, and it really highlights the inefficacy of paroxetine for treating bipolar depression. This was a study that was embedded in the quetiapine regulatory trials. Paroxetine monotherapy was no more effective than placebo in treating depression. And in fact, the switch rate of the SSRI resembled the natural switch rate of the illness, and both were significantly higher than quetiapine. Meta-analyses continue to be done, and the overall picture is antidepressants in comparison to placebo or some studies with comparator agents has no added benefit from a point of remission or response. The last blue bullet is interesting. If you think about all the advances that have been made for atypical antipsychotic augmentation for major depression, and we had some great data on that this morning, this is where you start to see differential effectiveness of antidepressants. When the antidepressant is lined up with an atypical antipsychotic, we do see benefit. When the antidepressant is lined up with a mood stabilizer, lithium and an anticonvulsant, we do not. So overall, there is not a signal that would suggest the level of use of antidepressants in bipolar disorder is following an evidence base. The one exception would be bipolar type 2 illness. And I think we're getting a clearer signal that is emerging. And I just highlight two of these studies, and the bottom one was done here at UCLA. This was a study from Lori Altschuler's group that compared sertraline to lithium to the combination. Both of these studies really showed the benefit of the antidepressant, whether it's an SNRI like venlafaxine or the SSRI sertraline, and they do not show any switch rate or additional benefit of combination treatment with lithium. Again, another study from the Stanley Foundation Bipolar Network. Michael and I were involved with this with Lori, and this is a study that proves to I think be compelling for me still 20 years later. So this was a trial design where bipolar patients on mood stabilizing agents who were depressed, got on an antidepressant, didn't get manic, didn't drop out, didn't have side effects. There's a reason there's so many cuts to that data. When we follow them longitudinally to see what happened when the antidepressant stopped, you can see it there. For those individuals who stopped the antidepressant within 6 months, they relapsed back into depression. There was no additional risk for mania after probably a therapeutic window of about 3 months. So to me, what this says is that there really is a cohort of our patients where antidepressant therapy should be considered a mood stabilizer. And how do we find out who those patients are and get them to these treatments right away? So, sorry for throwing a lot at you right away. What I'm trying to present here is, I think, one of the most interesting neurobiological mechanisms in psychiatry, and it's this switch process. So individuals who are depressed and cycle into a manic episode or vice versa, and that is not just a drug-related phenomena, it is an illness-related phenomena. But we got really keen to better understand that. And what I'm showing you on the left part of this slide is all the clinical risk factors that have been associated with antidepressant-induced mania or antidepressant-associated treatment-emergent mania. There's some nomenclature arguments in the field, but I'll just have you walk through that list. And if you think about that patient perspective, if I'm considering an antidepressant for a patient of mine, I'm literally walking through each of those blue bullets and I'm generating kind of a cumulative risk. Is there a mood stabilizer on board? Scandinavian registry data would suggest that there is a window of vulnerability of an antidepressant-induced mania. And if you've not had it within the first 3 months, the likelihood that you will is negligible. We all know that the tricyclic antidepressants have that risk. The mixed depression is a feature that's there, age, bipolar 1. Serotonin transporters have been a lot of interest as of late. And I can remember a lecture from Karen Miato when she was a resident and I was 2 years behind her. So this has been in the field for a long time. But we just published, if you look at 6 or 7 studies of serotonin transporters and the S allele, its risk of antidepressant-induced mania, it's positive. Do I think that is remarkable data that's going to change the field? Absolutely not. But it is a signal that there are biological measurements we need to be thinking about and start generating risk models that have clinical variables, biological variables, current presentation variables, and really put those all together. So as we start thinking about new ways to study this switch process or the antidepressant-induced mania, I wanted to show you 2 of our new studies that are really encouraging us to think very differently about this. And working with our statistical geneticists, we've come to use the study methodology of polygenic risk scores. These are combinations of genetic variants and individuals' genetic loading that is used to predict a risk, i.e. bipolar disorder, yes or no, or a response. And in this case, antidepressant-induced mania. We wanted to look at antidepressant-induced mania and bipolar disorder and look to see how similar or different that was to antidepressant response in major depressive disorder. So we use the PG polygenic risk score summary statistics from the largest antidepressant study completed by Payne and colleagues in 2020. And we use that polygenic data to look at our patients in our bipolar biobank who were rigorously phenotyped as having been on an antidepressant within 8 weeks becoming manic. Now, we were very interested in the GWAS study, which showed no significance at all. But we were really intrigued to see that those individuals that had a high polygenic risk score for antidepressant response in major depressive disorder was associated with a higher odds of treatment emergent mania in bipolar disorder, perhaps suggesting that there is a spectrum of efficacy based on polygenics, that it's a response in major depression and it's a mania in bipolar disorder. What got us even more confirmed this was a space we wanted to stay in is that polygenic risk score looked higher for individuals with bipolar 1 than bipolar 2, and that resembles the clinical literature. What doesn't is that the SSRI looked equal to the SNRI. That's not a clinical perspective that I have, but I suspect that's really a sample size. We've also been very keen to understand mitochondrial energetics, recognizing that this is it is well studied in bipolar disorder, not optimally understood. But if you think about the electron transport chain, Anna Andreazza has been doing some very good work looking at complex 1. Sue Tai, who was at Mayo Clinic, is an active collaborator with Jennifer Cruz, has an animal model of mania that really keys into complex 4. Hillary Bloomberg at our recent BD squared meetings doing some interesting work at complex 5. So in the upper left part of this slide was a preclinical group at Mayo that simply did a systematic review of all clinical studies, looking at psychotropic drugs, and asking at any point along electron transport chain if those psychotropics increase mitochondrial functioning or decrease. And with a rigorous, very conservative point of view, that's why that mixed column is so large, they categorize psychotropic drugs as to either increasing mitochondrial energetics, paroxetine, nortriptyline, venlafaxine, decreasing mitochondrial energetics, amitriptyline, escitalopram. Manuel Gardea Resendez, who was a postdoc at Mayo, is now back recruiting in our biobank from Monterrey, Mexico. simply took that category, brought it to our bipolar biobank. We have a deeply phenotyped cohort of individuals who have antidepressant-induced mania, or individuals who've been on those antidepressants and did not have a manic episode, so they are our control. And what I'm showing you in the bar is that those individuals who had antidepressant-induced mania with antidepressants that have been shown to increase mitochondrial energetics at a significantly higher rate of antidepressant-induced mania than those drugs that have been shown to decrease mitochondrial energetics. Longer story at some later point. What really lines up with this data is this concept of a window of vulnerability. That is, there is a 3-month period clinically where antidepressant-induced mania does not occur, it's unlikely to do so. The preclinical mitochondrial studies have that same acute kind of mechanism to it that we think is important, and we are planning to better study this. So how might you consider this if you were interested in machine learning and developing AI algorithms that could help clinicians and individuals considering antidepressant therapy really understand the risk of this type of treatment? So I'm showing you all the clinical variables that I just showed 2 or 3 slides upstream, but then kind of think about a high risk and a low risk. And maybe we need to develop more rigorous models, but a high risk might be a 16-year-old female who is hazardously drinking alcohol, has a positive family history of bipolar, has a highly recurrent depressive condition, and she has reduced serotonin transporter function at SLC6A4. That might be someone who we would conceive clinically as a high risk of an adverse event of an antidepressant, and maybe we should do something else. Lamotrigine, an atypical antipsychotic, whatever that might be. A low risk patient might be a 50-year-old treatment-resistant depressed bipolar 2 who's already on atypical antipsychotic augmentation and doesn't have anything of note from a pharmacogenomic or pharmacokinetic perspective. I would like to see some of these risk models incorporating polygenic studies, mitochondrial profiling. The data that I've just presented you has really galvanized us to partner with our mitochondrial colleagues at Mayo. And we have a mitochondrial metabolite platform that we have developed and are now using that to help stage bipolar illness in our biobank. So, burden, risk modeling. Wanted to talk now about how we might more focus our efforts on discovery science that leads into new novel treatments. And it has been an honor and such a pleasure to be working with this august group of collaborators in building the bipolar biobank at Mayo Clinic. This started in 2010. I think the reason this has been so successful is right away we partnered a subject matter expert with a statistical geneticist. So the design of this study was really from the very beginning, really about clinical phenotyping and how should the repository be built and stored to really optimally function. And the goal of this research resource, I'm making a pitch for anyone here. This is a rigorously clinically phenotyped cohort, and we want this biobank to be a research resource for the world. If there's someone interested in looking at a marker of disease risk or treatment response. We now have 3,000 individuals who've been gracious enough to partner in research. We have access to 60,000 age-matched controls. This has been a hugely successful endeavor, really related to relationships and collaborations, and want to recognize Susan McElroy at Lindner Center of Hope, Alfredo Cuellar Barbosa and Manuel Gardea Resendez at the Autonomous University of Nuevo León in Monterrey, Mexico, and Miguel Prieto at the University de los Andes in Santiago, Chile. The first study we did is here. So while we were building this biobank, we wanted to take advantage of existing data sets. And the clinicians told the statistical geneticists, this is a highly heterogeneous disease. We cannot develop phenotypes that are bipolar, yes or no. We have to narrow down. And one phenotype we were very interested from the beginning was bipolar disorder with obesity or an elevated BMI. And so this molecular psychiatry paper published by Stacy Winham is the public domain data set where we identified a genome-wide significant genetic variation, or SNP, TCF7L2, that was associated with bipolar disorder. The association was an interaction with BMI. The higher the BMI, the greater contribution of disease risk this genetic variant had. While we're analyzing the TCF7L2 SNP, we're building our bipolar biobank, and that is then the second study from our data set that replicates TCF7L2. TCF7L2 is one of the strongest risk genes for developing diabetes. And now we have a TCF7L2 SNP that is a risk gene for bipolar disorder. Beyond the scope of our time today, I wanted to show you the top study is really identifying the SNP, replicated. The bottom study is our molecular pharmacology colleagues, Duan Liu, that literally took the diabetes TCF7L2 SNP, the bipolar TCF7L2 SNP, developed neuronal stem cell models and compared these two. And it was the bipolar SNP, not the diabetes SNP, that showed great association in regulating insulin signaling in the brain, not the diabetes SNP, the bipolar SNP. This is an example, I think, of really taking discovery science, replicating it, understanding the functionality of the finding. And that really has led us into starting to think about GLP-1 agonists and genetic variants of response, and whether there might be a disease-drug interaction that we should be thinking about in the context of these types of treatments for our patients. One very simple example, and what I like about it is we're starting to really think out of the box. What about metformin for treating depression in bipolar disorder? This is an elegant study, small sample size, but it's really moving the field. 45 individuals with bipolar depression who were insulin resistant, and they were randomized to metformin or placebo. And insulin resistance, with the second black bullet, you can see is defined. And if you had established diabetes, you were excluded. The outcome measure of change of depression was related to who converted from insulin resistant to no longer insulin resistant, whether it be metformin or placebo. And I believe there was one patient who flipped from IR positive to IR negative with placebo. But what you see with those blue lines is those people who converted, the majority of them on metformin, were having a significant reduction in depressive symptoms. Obviously, everyone's very interested in the GLP-1 agonists that are of great interest for us as well. I've spent some time talking about the genetics. I want to be clear, this is not just a genetic phenomenon. We have looked at diet quality in over 700 patients who are in our bipolar biobank. And the way I'll have you appreciate this slide is the following. We use the REAPS. I don't know, are you using that in any of your work? This is the rapid assessment of eating. It would look at the last week prior to blood draw. It does not give you the composition of fat, protein, and carbohydrate. It simply is looking at diet quality. Are you eating a lot of processed foods? Are you eating a lot of fruits and vegetables, et cetera? Going from left to right, as diet quality goes down, BMI goes up, central adiposity goes up. The BIS-D is a Charlie Bowden scale looking at depressive symptoms. As diet quality goes down, current symptoms of depression go up, and the EDDS is a measure of disordered eating. As diet quality goes down, disordered eating goes up. You can't ask for more compelling data to say we can do a lot with drugs and omics, but we have got to change the way people think about nutrition because this can actually impact symptoms of depression. So a lot of interest in ketogenic diet. And as I was starting to learn about this, I thought I would go to the literature to find the oldest report, and it is in the Mayo Clinic Proceedings from 1924. This is fascinating reading. I'm quite sure you won't go there, but let me highlight the summary. And actually, the summary is really the patient perspective. I really liked the lecture this morning. There was a young man who probably went into 5-Domitilla with grand mal and petit mal epilepsy. He was placed in the hospital under close supervision. Ketogenic diet started the day he came into the hospital. He did have 2 grand mal fits the day before. He came in on April 9th. He was seizure-free until April 20th. And I suspect maybe one of the sisters of St. Francis or one of the nurses on an Easter holiday gave him a chocolate-covered egg, and he seized. Compelling. How that is working is far from clear. The main point in blue is that we're shifting the energy source when we go from conventional diet to keto, from glucose to beta hydroxybutyrate. And there is a lot of interest in studying that now. Shibani Sethi really, I think, has published the first open label feasibility trial in the United States. This just was last week. It's compelling. It is feasible. More importantly, it is acceptable. Patients are interested to really sustain that precision nutrition intervention. You can see that those who were metabolic syndrome positive were no longer. Weight is reduced, BMI, central adiposity, HOMA-IR, triglycerides, the whole thing. So we are going to be pursuing something similar at our site, and our cardiovascular medicine colleagues were appalled. And then we started having this conversation, and I showed them the 1924 proceedings. And there's one really great preventative cardiologist said, you know what, we have to better understand for whom does this work and why, and where do we have some signals of concern from a cardiometabolic standpoint. So our study hopefully we started this summer, and it has a robust cardiovascular biomarker component. So let me take the last couple of minutes. As you hopefully can appreciate the burden of the depressive phase of illness, the opportunity for more risk modeling or precision medicine of existing treatments that we have, recognizing that we are positioned now to really think about novel therapeutics through discovery science and how we're going to do that with BD squared. This is a collaboration that is unprecedented in scale, with the goal and vision, as you see here, that all people with bipolar disorder will thrive. The main piece of this BD squared is what I'm showing you here. Last year, a number of substantial awards were given in discovery, genetics platform, and brain omics. And I believe Nelson Frye and the UCLA team is part of the genetics platform. But the strategy here is harness what we know about genetics, brainomics, and novel discovery mechanisms, and start bringing these groups together and having them, hopefully soon, have an integrated network that can be a cohort of patients and individuals living with the illness to better target thriving and what that might be. And as Michael had said, the integrated network is getting started now. We have an inaugural 6 sites, and really honored that UCLA is leading the way with Jennifer Cruz. And I appreciate Michael and David's work as well. We have a big mandate here. We are going to enroll 4,000 individuals with bipolar disorder, follow them for 5 years, and hopefully change the way they live and really focus on measurements of thriving. UCLA will be joined by Mayo Clinic, the University of Michigan, Brigham and Women's Hospital, McLean, Johns Hopkins, and University of Texas, Houston. Our clinical coordinating center is Northwell Health. Our data coordinating center is INDOC, based in Toronto, and our biorepository is at the Mayo Clinic. What I think is truly unique about the integrated network is it has two main pieces that you see on the left part of this slide. All of us in bipolar research have been doing cohort studies for decades. This will be the largest in scope and the most deeply phenotyped, and again, 4,000 participants over 5 years. But what makes this unique, and the concept we think of is the following. This is a longitudinal cohort study embedded in a learning health network, where these individuals who are participating in research, we will partner with the electronic health record for them and start to look at new vectors of association from the EHR and an MRI scan, or EHR and PBMCs that are being procured. Cohort studies in an active learning health environment really is our integrated network. For those of you who are not familiar with the concept of learning health, the definition that you see here from AHRQ is a good one. It's a health system. So for example, UCLA would be a health system, but UCLA partnering with BD squared would be a learning health network. But the system has internal data and experience systematically integrated with external evidence, generating new knowledge that's put back into the practice. And that's the piece where we want to make sure we're doing that in real time. If you have a new drug, it takes about 17 years to get from discovery to clinical practice. Same thing with clinical innovation. It takes too long. The concept of the learning health network is you identify that new data and it gets reinvested back into practice in real time. You cannot have a learning health network if you don't have people, technology, and active learning. I think the people piece that is really important to underscore here is, yes, we need leadership, but we need clinicians in the trenches taking care of patients. You know where the gaps in practice are. We need to hear what they are and set up ways to answer questions that can address those gaps. And as important, we need individuals with lived experience who feel they are participating and building the network with their providers and learning from that. We have to have technology that allows clinicians and researchers to get to this data in real time, analyze it, think about it. UCLA looks at their data, they scale it to the network, we scale it to the world. And this concept of active learning, think about quality improvement programs. That's kind of similar on a much smaller scale. You identify a problem, you develop a quality improvement project, it either works or it doesn't. If it works, you change the practice. If it doesn't, be brave enough to stop doing that practice and do something different. So to our knowledge, BD squared will be one of the first learning health networks that again has this direct link to a cohort protocol, discovery grants, genetics, and brainomics. So in conclusion, hopefully you appreciate today that evidence-based options for bipolar depression are limited. And I think this is really related to the complexity of study design. You have to account for the other pole of illness. You don't have to do that in depression, schizophrenia, or alcoholism. And that has directly related to substantial lack in drug development. The evidence base of using antidepressants in bipolar disorder does not align. Sorry, the clinical use of antidepressants in bipolar disorder does not align with the evidence. That's a gap in practice. So gaps in practice are what the Learning Health Network can close. And I think we need to start really conceptualizing risk modeling as to when we would pursue something versus when we would not, and really see the potential of learning health networks to scale precision medicine initiatives, better design healthcare delivery teams, and really educate new generation of mental health practitioners. This has been an enormous enterprise. I'm so grateful to colleagues and friends at Mayo Clinic. UCLA, NIMH, collaborators all over the world. I wanted to show you when our Stanley Foundation Bipolar Network got started. Lori Alter is in the green sweater with the necklace. I'm the one in the back with the non-white beard. And our fearless leader, Bob Post on the left, and at a reunion some 25 years later. Pretty amazing. Mentors along the way. Really is wonderful to be back with Michael, and Lori was such a major influence in my career. I'm honored to be back. Thank you very much.
We're now to the Q&A part. We have some questions from the Zoom audience. And for those of you in person, feel free to raise your hand. So anything, first of all, in person? Yes.
I was curious, is there some link between these SNPs you found kind of related to BMI and then like the cellular energetics piece, what you're talking about with like the electron transport chain? Or
so I would say yes, but I don't know what that link is quite yet, but it makes sense, right? If BMI is probably a very strong measure of unhealthy glucose utilization, but how that links back up, we'll have to rely on you to answer that question.
One of the questions, oh, yes, John.
Just curious, so I think the data showing the effect of antidepressant and mitochondrial activities are fascinating. I'm just curious from a clinical point of view, do you recommend you want to pick an antidepressant treating bipolar depression? Should we pick one from the ones that increase mitochondrial activities?
So that's actually a really important point. Has that single study, albeit in a high impact journal, changed clinical practice? Not really, because the ones that really kind of were there were venlafaxine or triptyline. I wouldn't be using them anyway. Paroxetine just has so much kind of anticholinergic burden. And if you're a poor metabolizer at 2D6, those levels get really high. So I don't think it's changed my practice, but my practice, I'd like to think, was well informed prior to that. But it's a really important example of a single study really doesn't change clinical practice. We need to replicate that data. We need to better understand more additional ways of thinking about mitochondrial functionality, like seahorse designs and things like that. So it hasn't changed it yet, but stay tuned.
One of our Zoom questions is, please comment on the seeming disparity between STEP BD, I gather the kind of negative studies on antidepressants for bipolar depression, and the Altshuler maintenance discontinuation study.
So the STEP BD is a very different cohort than the Altshuler study. So STEP BD is really bipolar patients on a mood stabilizer, and it's an acute and an extension study. I think the Altshuler study, single site, which does provide more power. The reason I kept going like this is when you look at that cohort, it turns out to be about 10 to 15% of the sample size. This is a minority of patients, but it's so narrow in its phenotype, I think it informs the field. So I would argue that I see them as very different studies with different conclusions. And I don't think it's productive for us as a field to say, you know, as Michael knows, for 20 years, we've had people say these drugs work and, you know, stand on top of the podium, and, you know, another group that say they don't, and they're equally as vociferous. I think the real question is, for whom do these work? Why is that? And how do we really get these precision medicine treatments to them sooner?
Yes, Jen.
Could you also kind of integrate what you were just saying with the recent, I think it was in the New England Journal, the big, where, you know, the top line results basically that were the primary outcomes, remission response, manic switching, were non-significant, if I recall correctly. But then when you actually read the article, like, it showed that same thing, that the L'Oreal learners, right, where people who stopped it got
Yep.
sick of it.
So the primary the study failed. I mean, I think they had to close either for COVID or inadequate sample. So I don't think it's informative from the standpoint of do they work, yes or no, but a critical reader will see there's some secondary analyses that are very informative. I mean, if you ask docs how many of their bipolar patients are on antidepressants, it's an enormous number. That can't all be sort of anecdote and misguided. So I think it's really trying to find. I think we're big believers in narrow phenotypes, understanding that biology, and then disseminating that to change practice.
We have 1 minute, so short answer to a long question. Please comment on the potential value of this modified form of lithium currently under development that has improved blood-brain barrier penetration, which could allow for lower therapeutic doses and less nephrotoxicity.
Let's study it. Sounds intriguing.
That was a great short answer to a long question. Okay, thank you, Dr. Frye. Thank you for coming out. And we'll see you again soon. Bye.